Welcome to this Step 3 review on common rashes and skin conditions, brought to you by Roadmap to Residency. Dermatology on Step 3 is less about memorizing every rash and more about recognizing a handful of classic pictures and choosing the right next move. Today we cover eczema and psoriasis, acne, fungal infections, and when a lesion needs a biopsy. Our goal is to show you how these stems are built and how to attack them quickly. Keep working your question bank alongside this video because these visual patterns are learned by doing. Let us get started. Here is our plan. First, recognize eczema and psoriasis from a few words and pick the first-line treatment. Second, walk the acne ladder from topicals to systemic therapy, including the classic setup for oral isotretinoin. Third, cover the common fungal infections, the visual clues that separate them, and the simple test that confirms them. Finally, nail down when a lesion actually needs a biopsy, a favorite next best step question. Along the way, we will work practice questions and explain why each choice is right or wrong. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Let us start with the two rashes that show up constantly. The exam wants you to tell them apart from a few words, then choose treatment. Eczema is the itchy, poorly defined rash in the flexural creases, the front of the elbows and behind the knees, traveling with a personal or family history of asthma and hay fever. Psoriasis is the opposite, sharply demarcated plaques with thick silvery scale on extensor surfaces, scalp and nails, often with nail pitting or joint pain. Once you name the rash, treatment is straightforward. For both, first line is a topical corticosteroid, and for eczema, you add generous moisturizer. Match the steroid strength to the site, low potency on the face and skin folds, stronger agents for thick plaques on the body. Systemic medicines and light therapy are reserved for severe or widespread disease, so they are rarely the first best step. Now acne, which the exam tests as a treatment ladder, figure out where the patient sits, then choose the very next rung, not the top. For mild comedonal acne, whiteheads and blackheads, start with a topical retinoid. For mild to moderate inflammatory acne with red papules and pustules, add topical benzoyl peroxide and a topical antibiotic. Here is the single most tested trap. Never use a topical antibiotic by itself, because that drives resistance. It must always be combined with benzoyl peroxide, so an answer offering an antibiotic alone is wrong. When disease is moderate to severe, add an oral antibiotic like doxycycline. Finally, severe nodular or scarring acne that has failed these steps is the classic setup for oral isotretinoin. Expect a follow-up point about 2 negative pregnancy tests, strict contraception, and monitoring lipids and liver enzymes. Next, the common fungal infections. 3 moves: recognize the pattern, confirm it cheaply, then choose topical before oral. First, the patterns. Tinea, or ringworm, is the itchy ring-shaped patch with a raised scaly border and central clearing. Tinea versicolor gives painless patches on the trunk that fail to tan. Candida likes warm, moist skin folds and shows satellite lesions around the main patch. Second, when the diagnosis is not obvious, the cheap confirmatory test is a potassium hydroxide preparation of a skin scraping showing hyphae. That bedside test is the right next step, not an expensive biopsy or culture, and versicolor gives the classic spaghetti and meatballs appearance. Third, treatment. Most are treated with a topical antifungal cream. Know the 2 exceptions needing an oral antifungal: scalp infection with hair loss and nail infection. Topicals cannot penetrate the hair shaft or nail. Our first practice question. A 24-year-old woman has an itchy rash in the creases of both elbows and behind both knees. She has had similar flares since childhood and also has seasonal allergies and asthma. The skin is dry, red, and thickened, with no pus and no fever. What is the most appropriate initial treatment? Before you look at the options, name the rash in your head. The itch, the flexural creases, the lifelong history, and the atopy all point to one diagnosis. Choose your answer, and we will walk through the reasoning on the next slide. Let us break this down. First, spot the pattern. Itch, flexural creases at the elbows and knees, flares since childhood, and a history of asthma and hay fever are textbook atopic eczema. Dry, red, thickened skin without pus fits chronic eczema rather than infection. Second, apply the rule. First line is a topical corticosteroid to calm the flare, plus regular moisturizer to repair the barrier and prevent the next one. So the answer is choice B. Third, eliminate the rest. An oral antifungal treats a fungal rash. and this is not fungal, so A is out. Oral prednisone in C is far too much for a localized flare and tends to cause rebound. A biopsy in D is unnecessary when the history and exam give you a clear clinical diagnosis. Remember, doing too much is wrong just as often as doing too little. The answer is B. Our second question, all about the acne ladder. A 17-year-old boy returns with acne that has not improved. Over several months, he has used a topical retinoid, then topical benzoyl peroxide, and later an oral antibiotic. Despite that, he now has many deep, painful nodules on his face and back that are starting to scar. He is otherwise healthy. What is the most appropriate next step? The key words are severe, nodular, scarring, and failed the earlier steps. That combination should light up one specific answer. Pick it, and we will reason through it next. First, locate the failed step. The stem deliberately walks you up the ladder. Topical retinoid, then benzoyl peroxide, then an oral antibiotic, and he still has deep, painful nodules beginning to scar. Severe nodular acne that has failed standard therapy is the exact indication for the next rung. Oral isotretinoin is the answer, choice C. It treats severe, scarring, treatment-resistant acne, and starting now can prevent permanent scars. The distractors. Continuing the same regimen in A wastes months, while scarring worsens. A topical antibiotic alone in B is both too weak and the classic resistance trap. Reassuring him that acne resolves with age in D ignores scarring, we can prevent right now. Remember the safety points: 2 negative pregnancy tests in patients who can become pregnant, strict contraception, and monitoring lipids and liver enzymes. Now, one of the highest yield decisions in dermatology, when a lesion needs a biopsy, think of 2 buckets. First, biopsy the worrisome lesion. Anything that could be skin cancer needs a tissue diagnosis. Recall the melanoma warning signs: asymmetry, irregular borders, more than one color, diameter larger than a pencil eraser, and most important, a lesion that is changing over time. A new or changing pigmented mole, or a sore that will not heal, is a biopsy answer. Second, do not biopsy the obvious. When the diagnosis is already clear, like classic eczema, psoriasis, or a simple fungal rash, jumping to biopsy is the overkill trap, and this exam plants it often. Treat first. Reserve biopsy for 3 situations: a lesion that looks malignant, a rash that fails correct treatment, or a case where you must confirm a serious diagnosis before acting. Our third question, testing the fungal patterns. A 30-year-old runner has an itchy, scaly rash between his toes and along the sides of both feet. The skin is peeling and slightly cracked, and one patch is ring-shaped with a raised, scaly border and central clearing. He is otherwise healthy. What is the most appropriate next step? 2 clues should jump out: the location on the feet in an athlete, and that classic ring with central clearing. Name the diagnosis, then remember the rule about topical versus oral. Choose your answer, and we will reason through the options next. First, name the rash: an itchy, scaly rash between the toes in a runner with a ring-shaped patch showing central clearing is tinea of the foot. If you needed confirmation, the cheap bedside test is a potassium hydroxide preparation showing hyphae. Now the key rule: topical beats oral here. Skin tinea is treated with a topical antifungal cream, so the answer is choice A. The distractors. A high-potency topical corticosteroid in B would worsen and mask a fungal infection, a favorite trap. A biopsy in C is overkill when the picture is this classic. An oral antifungal in D is the tempting wrong answer, because oral therapy is reserved for the scalp and the nails, not simple skin tinea. Naming the rash and remembering the topical versus oral rule pointed you straight to the answer. Here is the pearl that ties every dermatology question together. Picture first, then treat. Skin questions bury the diagnosis inside the description, so before you look at the choices, translate the words into a named condition. Lock onto a few features every time. Location on the body, whether the border is well or poorly defined. The color, the presence and type of scale, whether it itches, and history clues like a topy, being an athlete or a changing mole. Name the rash first, always. Then simply choose the correct step on that condition's ladder. Topical steroids for eczema and psoriasis. The acne ladder up to isotretinoin. Topical antifungals before oral, with scalp and nails as the exceptions. Biopsy for the worrisome lesion, not the obvious one. When two answers both look reasonable, pick the simplest one that works and steer away from the overkill trap. That wraps up our review of common rashes and skin conditions for Step 3. For eczema and psoriasis, name the rash from the location and description, then reach for a topical corticosteroid. For acne, climb the ladder in order, and never use a topical antibiotic by itself. For fungal infections, recognize the pattern, confirm with a potassium hydroxide prep, and choose topical before oral, saving oral agents for the scalp and nails. For biopsy, act on the worrisome or changing lesion, but do not biopsy an obvious rash you can simply treat. Above all, picture first, then treat. Drill questions under timed conditions, read every explanation, and study the clinical photos in your review resource. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this helped, please like and subscribe. Good luck on your exam.